Hello, good evening everyone to this Lung Cancer Connect 2022 virtual conference uh, organized by Dr. Sajjan Rajpurohit, who is a Director, Department of Medical Oncology, BLK Super Specialty Hospital, Delhi. Sir, I request you to take over, sir.
Thank you so much. And it is my proud privilege to have this 2 day extravaganza on lung cancer, which will include all the aspects of lung cancer and how lung cancer treatment has evolved over the last 1 year. And we have very eminent speakers and also an international speaker who will be taking part into this meeting over the next 2 days. So the first speaker for today's evening is none other than Dr. TP Sahu. Sir is a senior medical oncologist and a mentor to many of us. And he belongs to Bhopal, and he teaches all over the country. And I always look forward to meeting him in person. But COVID has been holding us back. So without wasting much time, we'll start with the first session. The first session, the topic will be the systemic management of early lung cancer or resectable disease in lung cancer. Over to you, sir.
Thank you, Sajjan. The feeling is mutual, and that's all I can say. And without delaying it any further, it's always a privilege to be here among all of you and be able to speak. Uh, um, just let me know once my slide is full screen, or is it not full screen?
No, sir, it's not full screen.
Okay.
Just make it full screen.
Yeah, just I'll. Is there now?
Yes, sir.
Yes, sir.
Yes.
Yeah. So now I would like to first of all, I'd like to thank the organizers and Sajjan especially in particular for inviting me into this meeting, and I hope I can be of some use to all of you. In the next 10 to 15 minutes, I will be just going briefly over especially what we can do as medical oncologists regarding the operable lung cancer. That's what has been given to me. The topic it may sound, but I feel I clarified with the organizers I am going to speak on systemic therapy. So if you look at it, and the point is most of the patients of lung cancer, irrespective of stage, do relapse. And most of the lung cancers, let's say in stage 1B also, you would have around 40% of them having a relapse, and it does grow as the stage grows. And around stage 3, the relapse rate can be as high as 70 to 80%. So this gives you an idea that we need something in the form of systemic therapy so that these patients can be achieving more cure rates. And that is why we need an approach which could be neoadjuvant or adjuvant. First, I'll go to neoadjuvant because this is a field that is growing very fast. The data is evolving. Although it's not a standard, but the data, especially from the checkmate, looks very, very promising. And I'm pretty sure if one more data follows up with the same advantage, we would be speaking of neoadjuvant in operable lung cancers in a big way. So why neoadjuvant? Improved physical fitness and compliance is one thing why we need to look at neoadjuvant, because around 20 to 30% of patients post-surgery of lung cancer are not able to receive adjuvant chemotherapy, although they're eligible to do that because of post-op complications. Recovery is slow. They are not fit for receiving chemotherapy. Second is, you can also study the in vivo radiological and adaptive response of the tumor to systemic therapy, which is meaning like in a TNBC as we have done, or let's say in HER2 new positive breast cancer, we do the neoadjuvant, we look at the PAT-CR. If the PAT-CR is not there, we try to change the protocol, add something else like we add capecitabine or we add a TDM1 if they do not get the PAT-CR with the neoadjuvant therapy. So same, can it be done for lung cancer? Too early, but that is the way I think it is going to evolve. So if someone achieves the PAT-CR in lung cancer who has received a chemo and immuno, most of the times they will just receive probably adjuvant immuno. Chemotherapy can be taken away, but it's too early. But that's the way I think the world is progressing. Also, the opportunity to study the dynamics and the mechanism of anti-tumor response. That is something which I feel is very, very important, and this gives the advantage of neoadjuvant therapy. If you look at it, the neoadjuvant immunotherapy has been observed to facilitate the early development of the memory T cells. So what happens by this is they induce a strong adaptive anti-tumor response, and that probably is the advantage of patients, how they can be cured more even in the later part when there's a micrometastasis coming. These memory cells get activated and this can take care of a possible relapse. And that is probably why people are so much interested in the neoadjuvant approach. The uniqueness again for lung cancer comes for the unique concept of lung cancer. We are not looking at PATCR alone. We are also looking at a major pathological response in lung CR. Anything equal to 10% or less of viable tumor cells would mean that the patients would more likely to do well post neoadjuvant therapy. It is, if the patient has not achieved this amount of response, probably the patient is not going to do that well, and probably we have to modify our adjuvant treatment. So if you look at the neoadjuvant TKI, the trials are very, very small. Their numbers are small. You would not take any conclusive evidence from it. And usually the trials have given neoadjuvant TKI in the EGFR positive population for around 1.5 to 2 months pre-op. The largest data has come from the emerge CTONG 1103 study. And this is a study where they have screened 380 odd patients, 72 were enrolled to receive erlotinib, or that gave gemcitabine platinum, which probably in adenocarcinoma we would not be using it today. But at that point, we did use gem carbo, and that was the randomization arm. And what happened for this was, and this was especially bulky patients, most of them had N2 nodes. If you look at it, 50% of this patient had multiple station N2 nodes. And the EGFR activity, the mutations were there in exon 21 in around 56%, and the 19 was around 16%. The response rate for neoadjuvant erlotinib versus the chemotherapy was more towards the erlotinib, but it was not statistically significant. And the PFS, although was significant, but it did not translate into survival advantage. This is the maximum we have of the neoadjuvant TKI. Major pathological response, what we told, less than 10% of the viable cells were observed in 10% of erlotinib, while none achieved in the chemotherapy arm. So this is all we have the maximum data. So in neoadjuvant setting, TKI, no, till you have a very frail patient, not fit for chemo, and consent is well taken. If you look at immune checkpoint single agent, multiple trials, 1 cycle, 2 cycles, 3 cycles, you have across for Nivo, for Atizo, for Durva. And if you look at it, the major pathological response is around 20 to 40%. The pathological CR is around 5 to 10%. The response rate are not that huge. All of us know the median survival is normally not reached, and the complications are not typically which we cannot manage. Even there is a data, the NeoStar published last year for 3 cycles of nivolumab preoperatively versus 1 cycle Nivo and EP, and just 1 cycle, and look at the major path response, 21 versus 38 in towards favor of the IOI combination. Path CR 3 times more than 3 times in favor of the IOI combination. So is it the way we should do 1 cycle of just IOIO as a neoadjuvant and look at the amount of PATCR we see? But the maximum data has come from this phase 3 trial. If you look at it, the nivolumab and chemotherapy versus chemotherapy once in 3 weeks, and this patient had eligible for chemotherapy at least stage 1B and beyond, 2-3A, did not have any driver mutation. They were randomized to Nivo and the chemotherapy for 3 cycles, and then they went for surgery after a break of 6 weeks, and there was an optional of adjuvant chemotherapy. These patients were 64 to 65, little bit on the elderly side. The squamous cell and histopathology and the non-squamous were half 50-50. You had stages, more so of the stage 3A, and the PDL1 was not evaluable for 7%, and lesser than 1 is around 44%. So 50% did not have a PDL1 positivity. And look at what the trial showed. You did achieve the PATCR, which was more in favor of the Nivo chemotherapy arm, 24% versus chemotherapy versus 2%. More of the patients on the combination arm did go on to receive lesser invasive surgeries. That is one more thing, that the patients did receive lesser invasive surgeries. The hospital stay was nothing much to talk about, so the combination arm was favored. But there are many questions unanswered. How many cycles are optimal? 1, 2, 3, we don't know. Can we combine with the CTLA-14? The NeoStar told, yes, we can do 1 cycle is enough, but is it the last thing we are hearing? No. Do we need adjuvant chemotherapy? What regimen, what duration is still not known. And what about the PD-L1 status? Are these patients going to be treated as per the PD-L1 positive and negative? We also don't know. But as of now, we don't treat them. We treat them same irrespective of the PD-L1 status. Adjuvant, shifting gears to the last few slides. Adjuvant, if you look at it, we have been practicing chemotherapy adjuvant because of the 4 to 5% benefit which we get in this anyone beyond 4 centimeters size of tumor. And this is because of the LACE meta-analysis which is there. But one trial has to be told, the IM-POWER 010 on the adjuvant setting. These patients, again, 1B, 3A, this included the patients who had driver mutation. Adjuvant chemotherapy was given to 1 to 4 cycles, and then they were randomized to atezo and best supportive care after surgery. And if you look at it, post-surgery, adjuvant 1 cycle of chemo to 4 cycles max, and then they were randomized to atezo for 16 cycles versus best supportive care. And when they looked at the data, look at again the non-smokers is around 60 to 65%, the never smokers were around 20%, stage 3 and stage 2 were the major patient chunk of this trial. And this patient, if you look at PDL express patient, the hazards was 0.66, means 35% benefit for those who received adjuvant immune checkpoint inhibitors. But when you look at the right side, the EGFR mutation subgroup and the ALK, the benefit was not there. So we probably should not be giving this adjuvant immune checkpoint for the patient having this driver mutation. But irrespective of that, when we looked at all stages, because this included stage 1B to stage 3, and this was the 0.66, if you look, was only for this expression of PD-L1. But if you look all patients, the benefit was still there, but the hazard shrunk from 0.66 to 0.79. Again, the benefit was maximum documented for anything having more than 50%. So if someone has the money, someone has the score of more than 50% of PD-L1 and not having a driver mutation, that is the patient probably that will benefit from an adjuvant immune checkpoint. But beyond 1% also, the benefit is there. For EGFR mutation positive, all of us know the ADAURA is there, which has shown that there is a DFS benefit. All of us are looking for the OS benefit. The argument can go on, but this point, I think ADAURA has to be discussed with the patient. The right patient group has to be given this option. Duration, does it matter? Because everyone cannot afford the original osimertinib. Do this data of adjuvant gefitinib hold ground? It was significant for the PFS. OS was not beneficial. But here, this graph tells me one thing, that patient who received gefitinib beyond 18 months did do much benefit than those who received less than 18 months. So osimertinib for 3 years, was it the key? And can we replace it with 3 years of gefitinib? I don't think so. The data is not there. But I think we Indian doctors, because of the cost issues, are going to discuss this. So the consensus which was published from the Chinese group told that preoperative use of neoadjuvant immune checkpoint with or without platinum can be given in resectable 1B, 2A non-small cell lung cancer. That's what they feel. But NCCN does not feel that way. Is there any molecular marker? At this point, no. How many to give? 2 to 4 cycles is recommended. Review every 2 cycles and then plan your surgery. The gap should be at least 1.5, 4 to 6 weeks. Some tell maybe 2 months, but not beyond that. For neoadjuvant immunotherapy in non-progressive patients, especially achieving PAT-CR, we still could give for 1 year of adjuvant immune checkpoint. NCCN now is advocating the adjuvant IM-POWER 010 data, but the neoadjuvant is still not there in the NCCN. So to conclude, especially chemotherapy, all of us know, with immune checkpoint in the neoadjuvant might become a standard of care. We need probably more evidence for that. Something of a 2 or 3 trials duplicating the data. For the PD-L1 positive subgroup, stage 2, stage 3, adjuvant atezo and chemotherapy should be offered, at least for mutation negative and more than 50% PD-L1 expression. I think it is now an important discussion point with the patient. Third, EGFR inhibitors in adjuvant setting, ADAURA has told us we can do that. So with that, I stop and I thank Sajjan, and I'll be open to any questions in the chat because I think the conference has to go on without delay. Thank you everyone for a patient listening.
Thank you, sir. I think very crisply you have mentioned all the aspects, and it's very fascinating because for a long time we have not been into the neoadjuvant arena. So I think that's one area where in lung we will have patients coming to us for neoadjuvant also with over time. Adjuvant, sir, in today's world, like what is the best setting for EGFR patient, positive patient? You mentioned that Gefitinib could be one of the options. So in your practice, how are you dealing with such patients who cannot afford osimertinib?
First of all, I rarely get a patient who get operated for lung cancer. Fact number one. And in Bhopal, I have not seen a patient of lung cancer post-operative. I've seen only one patient in last 1 year. So that's the number of patient I see in as lung cancer who has been operated. So lucky for me, I don't have that dilemma. So if I have it, what I would do, I would push the patient for osimertinib. Would I push myself for not giving the so-called non-Indian, non-original version? I probably will leave it to the patient to choose the thing. But if someone cannot and have someone who has a high bulky disease, maybe for stage 3A or 2B, I probably will push the patient and discuss the data of beyond 18 months of Gefitinib versus less than 18. And I will take a consent that I do not have level 1 evidence. But if osimertinib can be afforded, it can be taken, that will be my drug of choice. There's no doubt about it. But if cannot, I probably will ink towards giving Gefitinib for at least 3 years. Because I feel if the lung toxicity can be taken care in Gefitinib, 3 years is the way to go. And that is why probably ADAURA was also positive. But the duration would have mattered.
I totally agree.
Manish is there, might have a different take if he's there. But I think that is my take.
Is there. Yeah, Manish is.
Because Manish had to go after me. So I think he would have been there.
Okay, sir.
Okay. So what do you think, Sajjan? Is that a fair way of looking at it?
Yes, sir. I agree with you, sir, because I think with more data coming from, because somehow, sir, these drugs, I don't know why they failed in the adjuvant setting, because probably there was some design failure was there, or some probably
if you look at it, even the Gefitinib, the PFS data was positive. The hazards were around 0.6, if I'm not wrong. The hazards were not that bad. Although the ADAURA hazards is something extraordinary. 0.2 and 0.3 is something that's extraordinary. But I think the drug is still active. Have we optimally used it? I don't know. The OS benefit was not there. So let us see how much benefit we're going to see of the ADAURA OS. And then probably we can then relate that with the Gefitinib adjuvant.
So, yes, sir. So if there are any more questions in the chat, I'll definitely refer them to you, sir. And thank you so much again for such a crisp and a wonderful presentation, sir. So we move on to the next presentation.
Thank you.
So
thank you,
the
sir.
Next topic. Thank you, sir. Thank you, sir. The next topic will be covered by Dr. Abhishek Raj. He is consultant medical oncology at BLK Max, and he will be speaking on targeted therapies for patients with metastatic non-small cell lung cancer. And over to you, Dr. Abhishek.
Thank you, sir. I hope everyone can see my screen.
Yes,
sir. You just have to go full screen.
Yeah.
Full screen.
Yeah. Thank you, Sajjan, sir. So it's a very vast topic. I have to cover this in 15 minutes. And I guess some of these topics will also be covered in the subsequent talks by Dr. Manish Singhal and Dr. Nagendra Sharma. So we'll try to cover this topic in the given time. So we know that historically this stage 4 lung cancer has been a bad disease, and like 10 years back, 10-12 years back, we were talking about survivals in months, like 9 to 12 months. But with the advent of personalized medicine and available of targets, we have been not only been able to improve the quality of life, but also overall survival with various drugs that have been available to us. So the non-small cell lung cancer, it's a very heterogeneous disease, and we can divide it based on the histology, like adenocarcinoma, squamous cell carcinoma, and then we have different targets that are available to us for targeting, like ALK, HER2, EGFR, BRAF, MET, and even in the EGFR mutation subset, we have a lot of different mutation that respond differently to different agents. So coming to first, we'll be covering the most common mutation, that is the EGFR mutation positive non-small cell lung cancer. So this is the EGFR gene. It is found in this EGFR activating mutation. It is found in 10 to 30% of the non-small cell lung cancer patients. T790M mutation, here the relative IC50 for these first generation TKIs is very high. So that is why they are resistant. This mutation is quite resistant to this first generation TKIs. While osimertinib, it targets this mutation even in the upfront setting or in the previously treated setting. So this is the trial on which osimertinib was granted approval in previously treated patients who were exposed to first-line TKIs. So the approval was based on AURA and AURA2 single-arm phase 2 studies of osimertinib in advanced setting. The overall response rates in both were 61 and 71% respectively, with a median PFS not reached in the AURA trial, while it was 8.6 in the AURA2 trial. This is the study which is comparing the response rates or the PFS of various generations of TKIs. So this is the study, CTONG 0901 study. So in this, this is comparing the PFS, median PFS of erlotinib versus gefitinib. There was no difference in the PFS, no statistically significant difference in the PFS between the two arms. And the same was observed even in the WGOG 5108 study, in which most of the patients were EGFR TKI naive. If we talk about the Lux Lung 7 study, there also between afatinib and gefitinib, the PFS was 11 months versus 10.9 months. And in the dacometinib study, which is the Archer trial, here the brain metastasis patients were excluded. And here the PFS was 14.7 months versus 9.2 months in the gefitinib arm, which was statistically significant. And this is the study of the FLORA study, which showed that osimertinib PFS was 18.9 months versus the standard of care erlotinib or gefitinib in patients who had mutated EGFR sensitizing mutation. Here also symptomatic brain metastasis patients were excluded, but asymptomatic patients were included. So we have seen consistently PFS of around 9 to 12 months with currently approved EGFR TKI in global studies since IPAS. And this is the efficacy of osimertinib. You can see that it is with a hazard ratio of 0.46. There is a statistically significant difference in the median PFS in the osimertinib arm versus the standard of care. What was even the duration of response was quite maintained. While it was 8.5 months, it was 17.2 months in the osimertinib arm, and so was the response rates also. So if we look at the data for subgroup analysis, you can see that almost every arm is favoring osimertinib compared to gefitinib and erlotinib, whether it was age, of racial, smoking history, baseline CNS metastasis or not, or the type of mutation. In every arm, there is a statistically these data was favoring osimertinib. We all know about these common side effects with gefitinib. We all know that afatinib and dacometinib, these are second generation TKIs, and there is slight tolerability issues. Probably the tolerability issues with these two drugs are much more as compared to gefitinib and afatinib. And particularly the diarrhea is quite troubling for most of us clinicians in dacometinib. Even afatinib causes a lot of diarrhea with a grade 3, grade 4 adverse events rated almost 49%. Similarly, in dacometinib also, 63% severe adverse events are seen. While the side effect profile is slightly more manageable for osimertinib, erlotinib, and gefitinib. So we know that a lot of these patients, lung cancer patients who are EGFR mutated, they have a propensity for brain metastasis, and this is probably because the penetrability of these drugs through the blood-brain barrier is less. So the disease is probably being exposed to the subtherapeutic level of EGFR TKIs that we are giving. So in these mouse studies, we have seen that osimertinib has probably the highest brain to plasma concentration ratio. So based on that, this is the data from FLORA. You can see that in osimertinib, CNS response was 64%. This is the waterfall plot showing CNS response of 64% versus 45% reduction in the CNS target lesion in the other arm. You can see that CNS progression was also much less in osimertinib arm as compared to the EGFR TKI comparator, and progression due to new CNS lesion was also less. So fewer patients, they progress CNS progression, and fewer patients progress due to new CNS lesion with osimertinib treatment compared to EGFR TKI. Although in the Archer study, dacometinib has not shown the symptomatic brain metastasis patients were excluded, but in subsequent smaller studies, dacometinib has shown a response even in the CNS. So this is the data for now. We have data for overall survival also available. This was published in NEJM. Here the median overall survival was 38.6 months versus 31.8 months in the standard comparator EGFR TKI arm. So this is the first drug which has shown overall survival benefit compared to erlotinib gefitinib in EGFR sensitizing mutation population. So this is the summary. So these third generation EGFR TKIs, they significantly give longer PFS, and with osimertinib we see the OS benefit also. And osimertinib is the only EGFR TKI to report intracranial efficacy. Even dacometinib's efficacy is there. And this is osimertinib is quite well tolerated at its recommended dose of 80 mg. Adverse events leading to dose reduction of the second generation TKIs are more frequent. Osimertinib was also highly effective in patients who were harboring uncommon EGFR mutation. And 7 out of 10 patients who start on first or second generation EGFR TKI will not be able to receive the benefit of best drug in the second line because some of them progress too fast, and by the time they present to you, they are probably not in a condition to treat. So now treatment based on ALK translocation. So ALK is probably the number of drugs that have come up in the treatment of ALK translocation. They are much more now as compared to EGFR, and although the frequency is lesser as compared to the EGFR mutation. So a total of 4% overall, with 33% patients who are EGFR negative, never smokers, with of course adenocarcinoma or adenosquamous carcinomas. Several ALK variants are identified, and it is detected by FISH or ALK-IHC. So this is the first trial. This is the Profile 1014 study. It was a phase 3 trial of ALK positive patients with non-squamous NSCLC with no prior systemic treatment. This is what had led to the approval of crizotinib as compared to chemotherapy. Median PFS was improved with a hazard ratio of 0.45, and overall response rates was also higher in crizotinib. If we talk about the other trials, this is the ASCENT study. ASCENT study, it included various groups. It included the ceritinib. Then we had alectinib. Alectinib initially it was tested in the second line study in the patients who had been previously exposed to crizotinib, and then with JALEX and ALEX trial, its approval was there for patients in the first line also. Then we have study for brigatinib, and now lorlatinib also we have data for first line. So this is the data for ceritinib. So ceritinib and alectinib, it was approved for patients with ALK positive metastatic non-small cell lung cancer with disease progression on or who are intolerant to crizotinib based on the excellent response rates that were achieved with both the drugs. So this is the JALEX trial. JALEX trial showed that as compared to crizotinib, in patients who were treatment naive, the median PFS was not reached as compared to 10.2 months with an excellent p-value and a hazard ratio of 0.34. We know that most of the ALK positive patients, they tend to have a higher propensity to develop brain metastasis. In fact, a lot of patients do present with baseline brain metastasis, and particularly with the second and the third generation TKIs, these drugs have excellent intracranial efficacy. And with the new data for lorlatinib mentioning that almost 80% intracranial response rates are seen in patients who are exposed to lorlatinib. So both these second generation, this alectinib and brigatinib, alectinib and lorlatinib, they have excellent CNS response. And even with ceritinib, you can achieve good amount of intracranial response even in patients who are pre-treated or they are treatment naive. You can see that in previously treated patients, response rates of around 40% are seen, intracranial response rate, while it was around 60% in patients who are not previously treated. With alectinib, it is around 75%. So this is an excellent number because CNS metastasis is often the cause of a lot of morbidity. So this is the summary that we should generally be treating the patients who have ALK mutation positive with second or third generation ALK TKI in the first line, because of the excellent response rates, excellent PFS, as well as intracranial responses. So ROS1 fusion. So this is also another fusion which can be detected by FISH or ROS PCR or IHC. It is one of the less common mutation. It is seen in around 1.2 to 1.7% of the patients. Usually, it's just like ALK, seen in never smoker adenocarcinomas with a high grade histology. Crizotinib is active in this drug, in this mutation. So you can see that this is the trial in which it was seen that 72% overall response rates were there with a median PFS of 19.2 months. Based on this, crizotinib was used for treatment of patients with ROS1 fusion. So now coming to the more rarer histologies, like we have now treatment available for BRAF V600E mutation, either vemurafenib, dabrafenib, or combination of dabrafenib, tramtinib. Now, high-level MET amplification or MET exon 14 skipping mutation, we can try crizotinib, but now we have data available for capmatinib with an excellent response rates and duration of response. RET rearrangements, cabozantinib has been tried, and with HER2 mutation, trastuzumab and afatinib has been recommended. Coming to the MET mutation, the MET exon 14 mutation, it is a mutation associated with quite poorer prognosis. It is associated with advanced age, and compared to patients who do not have MET mutation, they are associated with poorer prognosis and poorer response to even chemotherapy. Our non-small cell lung cancer patients. So
1 minute to conclude, please.
Okay, I'll just be skipping. This is the response to the therapy. So this is the most recent trial about capmatinib for exon MET14 skipping mutation. This included various group of patients, and the response rates was around 41% in patients who were previously treated, and there was one subgroup where 62% response rates were seen in treatment naive patients. For small cell lung cancer, you can see that overall response rates of 63% and disease control rate of 75% is seen with patients who were given with just monotherapy. Response rates of around 44%. See a median of 7 months and a duration of response of 8 months. For NTRK rearrangement, we had a paper where there is an excellent response seen by the end of 6 months. So these are all the mutations that are available to us for targeting, and this has opened a lot of ways for personalized patients who have non-metastatic cell lung cancer. Thank
you, Abhishek.
is usually a mutation that happens because of I think it's more like a selection clause, that if you're exposing the patient to your first line TKIs or like alectinib in the first line, so the mechanism of resistance is L858R, and it is usually resistant to most of the available first and second generation ALK TKIs. So that's for those patients, I'd probably use lorlatinib because it has shown that lorlatinib has more efficacy against this drug. Against this mutation.
This L858R is an EGFR. So just to elaborate.
I'm so sorry, sir. I thought you were talking about 1202R, G1202R. Okay. So I have been using, sir, dacometinib followed by osimertinib in EGFR mutation positive because of excellent PFS. And we don't have data for osimertinib in second line after exposure to osimertinib. Sorry, dacometinib.
And one more question just before we move to the next presentation. So for you in ALK, alectinib followed by lorlatinib, or lorlatinib and then followed by whatever the mutation comes?
I think, sir, alectinib followed by lorlatinib, because first of all, we have a much longer data available for alectinib. And if the patient develops G1202R mutation after exposure to alectinib, we still have another oral option that is available to us, and it is quite efficacious even in the second line setting, sir.
Thank you so much for answering these questions. And now and I thank you for this lovely presentation. Now we move to the next session. The next session will be by Dr. Nagendra Sharma. He is concerned medical oncologist at Medanta Hospital, Gurgaon. And Dr. Nagendra will be speaking on targeting EGFR exon 19 and exon 21 L858R mutations in the new era. Dr. Nagendra, over to you.
Thank you very much, sir. So these days, so many webinars are going on. The first question which is asked these days in webinars is whether my slides are visible or whether my voice is audible, sir. Can somebody from organizing team answer this question, please?
Yes, you're audible and visible.
Thank you very much, sir. So I will quickly come to my topics straightforward because already we are going late. The topic which is allotted to me is, one second, just will. Okay. So topic given to me is the targeting EGFR exon 19 and exon 21 L858R mutations in new era. So the question which is standing in front of us is L858R a different disease from deletion 19? This is what the question which is standing in front of us. And if we are able to answer this question, I think the purpose of my presentation will be over. So covering this topic in 15 minutes is an overstatement, but I will try to do justice with the topic. So personalized therapy with the EGFR TKIs, the timeline development, we know that the first FDA approval got from 2003. That was the first Geftinib TKI which was approved, and followed with there was plethora of options which over a period of time have opened up. And there was anticipation in the medical oncology community when Geftinib came into existence that there are many more drugs which are going to come in EGFR basket, and we'll be having a lot of options. And this came true also. And right now we are having more than 5-6 options as far as EGFR targeted treatment is concerned. So first generation, second generation, third generation, we know that erlotinib, Geftinib are the first generation reversible inhibitor which are inactive at the T790 mutant, and afatinib, dacofatinib, the second generation EGFR inhibitors, which are also irreversible covalent binding to EGFR, HER2/neu, HER4 to inhibit all the ERBB family signaling. They are having broader activity to overcome the EGFR TKI resistant mutations. Osimertinib, this is a third generation EGFR inhibitor, which is specifically acting on EGFR T790 mutant and EGFR wild type sparing activities. There is also irreversibly covalent binding to the mutant EGFR. So before 2000, we were having only best supportive or single or doublet chemotherapies. 2000 onwards, we are having first generation, second generation, third generation. So what is the PFS and overall survival benefit? What is the treatment evolution in EGFR landscape? So Geftinib came with a PFS advantage of median PFS of 10.8. Then erlotinib was 9.7 months. For afatinib, it was 11 months. Dacofatinib, it is 14.7 months. This is median. Overall survival also for dacofatinib was 34.1 versus 27 with the standard of care arm. Hazard ratio 0.76. For osimertinib, it is 18.9 months. FLAURA data we all know. And overall survival also published, it was 38.6 months versus 13.8 months and hazard ratio of 0.799. And one more thing I want to highlight, that Asian population, the median oral survival for dacofatinib was 37.7 months, and for osimertinib, the oral survival was 1 for those. Hazard ratio was 1 for Asian population. So it was not statistically significant for osimertinib in Asian subset, although the median PFS was equivalent for dacofatinib and osimertinib, that is 16.5 months. So progression-free survival for single agent TKIs, we are having LUX-Lung-7 trial, Archer 1050, and FLAURA trial, in which median PFS, as you know, it is 11 months. For afatinib, for Geftinib, it was 10.9. For dacofatinib, is 14.7 and 18.9 for osimertinib. Archer 1050, which is a trial for dacofatinib, which has shown that the median PFS, as you can see in the Kaplan-Meier curve, it was 14.7 months. With Geftinib, it was 9.2. That time, Geftinib was the competitor arm. Hazard ratio of 0.59. So that means it is statistically significant. Obviously, the patients have progressed later if they are used dacofatinib for these mutations. LUX-Lung-7 for afatinib versus Geftinib, progression-free survival, as you know, it was median PFS was 11, and for Geftinib it was 10.9, so more or less same only. Hazard ratio 0.73. But you can see there the 18% of the patients in afatinib were progression-free at nearly 2 years, and 8% for Geftinib arm. Flora data, median PFS, everyone knows, 18.9 months with standard of care 10.2 months, and hazard ratio of 0.46, and curves start separating. They are wide apart, favoring that it is favoring the experimental arm. We know that lesser the hazard ratio, better is the experimental arm, which favors osimertinib. Then came 2019-2020, that famous TMH data from Neurona v. et al., in which we have shown that when the platinum doublet was combined with first generation TKI, the median PFS was far better, and hazard ratio also significant. Median PFS for NEJ009, which was a Japanese study in which median PFS was 11.2 months, and hazard ratio 0.494. It was statistically significant. And for gefitinib versus gefitinib plus chemotherapy doublet, it was 16 months median PFS and hazard ratio 0.51, favoring the platinum doublet with gefitinib. This was an Indian study from Neurona et al. From TMH. Then first line TKI, if you put them in one line, that what are the median overall survival? By and large, if you can see, it was hovering around 25 to 30, 34 months. But right now, we are having a lot of trials which have shown the median overall survival also have jumped over 50 months now. LUX-Lung-7 overall survival benefit, as you can see, afatinib and gefitinib, in which the median overall survival of afatinib versus gefitinib was 27.9 versus 24.5 months. Flora overall survival benefit, if we put it across with Archer 1050 for dacopatinib, as you can see, it is favoring that those patients who are having osimertinib, the median OS was 38.6 months versus EGFR TKI for generation, the leverage was 6.8 months and hazard ratio 0.799. For Archer 1050 overall survival benefit, it was 34.1 months for dacopatinib, and for gefitinib it was 27. The leverage was 7.1 months. Hazard ratio 0.748, and p-value was significant. So mortality risk reduction was 25.2% for Archer 1050. That is a study for dacopatinib, and its mortality risk reduction was 20.1 months, 20.1% for osimertinib as far as Flora data is concerned. So PFS and OS, if you can see the Neurona et al., the median overall survival not yet reached, although the median PFS was 16 months, and for the Japanese study, it is 52.2 months as far as overall survival is concerned. And for erlotinib and bevacizumab, NEJ026 study, in which the median overall survival was 50.7 months and median PFS was 16.9 months. So there are four options right now. The median PFS, if we see that erlotinib was ramucirumab study, that is a relay trial, in which 19.4 months median PFS was there, although median overall survival not yet reached. And erlotinib, bevacizumab also 18 months of median PFS is there, although overall survival have not yet reached. So these are the studies which are happening across the globe, and we should be well aware of that. If you put all the overall survival benefits for first line EGFR targeted drugs, whether in combination or a single agent, as you can see, the median overall survival for the Japanese study is the highest, that is 50.9 months. For osimertinib, it's 38.6 months. For Archer 1050, that is for dacopatinib study, the median overall survival is 34.1 months. Hazard ratio is statistically significant. For Flora, it is 0.80. For Archer, it is 0.76. Now coming to L858R, there is a higher incidence of concomitant mutations and poor outcome. So retrospective cohort study from China have shown that those patients who are having L858R mutation, they are having more likely of developing co-mutations. The ratio was 69 versus 41% as we compare L858R and deletion 19 respectively. So median overall survival benefit and PFS have not yet, median overall survival not reached, but median PFS was 18.77 months. So TMB was higher for L858R, which as compared to deletion 19. This is also a factor which we have to understand in the back of mind when we are seeing a patient of L858R. Deletion 19 deletion have shown that there are higher doses improve median PFS and objective response rate in L858R, and this is what is depicted. The median or we can say objective response rate was 47.7% for L858R if we are using the lower dose, and if we are using the higher dose, it is 73.3 months, that is 73.3%. This is a very, very important slide in which we have to figure it out that how L858R mutation is different from deletion 19. So proportion of EGFR mutation, 40 to 45% will be on L858R as far as EGFR mutation is concerned, and 45 will be deletion 19. Locus will be A loop region in EGFR and alpha C helix region in EGFR in deletion 19. Clinical statistics, very, very important to understand. L858R, majority patients will be older. They will be having more common on the right side of the lung. Lipidic growth pattern is more common, and lymph node metastasis is uncommon in L858R as compared to deletion 19, which is more commonly seen in younger age group, more common in left lung. Papillary type is more common, and lymph node metastasis is also common. The prognosis, we all know that for L858R is poor, and for deletion 19 is better. Malignant pleural effusion, which is 32.6% for L858R, and for deletion 19 is 26.6%. The frequency of other mutation is 69% for L858R, and for deletion 19 is 41%. Sensitivity to EGFR TKI is low for L858R, and for deletion 19 is high. So deletion 19 and 21 L858R mutations have different biological characteristics, clinical features, prognosis, as well as different sensitivities to EGFR TKIs. Therefore, there is a need to subdivide EGFR mutation, and individualized treatment of EGFR subtypes will be a key issue now and in future too. So coming to IC50, the minimum inventory concentration in nanomole values for dacometinib for exon 19 deletion and exon 21 L858R substitutions are not very different, with IC50 values among lowest for dacometinib compared with other EGFR TKIs for L858R. As you can see in the picture down below, it is 2.6, and for Gefitinib, erlotinib, it is 26 and 16 respectively. Afatinib also is 4, and osimertinib is 9. So this is the minimum inventory concentration in which this drug is effective. Now, putting the overall survival benefit in overall population and those patients with L858R, so dacometinib has the same survival benefit in L858R exon 21 mutation population and the total population also. As you can see in the Kaplan-Meier curve, which is well depicted, that the median overall survival is 34.1 months with dacometinib, and leverage was 7.1 months and compared to Gefitinib, and mortality risk reduction was 25.2. As you can see in the lower end of this curve, the patient continued to derive long-term benefit with dacometinib. For overall survival with L858R, you can see that the median overall survival benefit is 32.5 months, and hazard ratios of 0.665 and p-value is 0.0203, both sides. So obviously this is showing that this is going to work irrespective whether you are using in L858R or not. FLORA, if we compare the FLORA trial, L858R, you can see clearly that it is touching the line of unity in the forest plot, and it is not showing any benefit because hazard ratio is 1. So it is not favoring. So mortality risk reduction was 0. If we are using osimertinib, we can carefully look at the FLORA data. For L858R, it is not the favorable drug, right? So concomitant therapy, as you can see in all the trials, NJ026, whether oral survival benefit. So A plus T, prolonged PFS significantly compared with TKI monotherapy in patients with L858R mutation, but which did not translate into oral survival benefit. There is no oral survival benefit. So this is the study in which L858R was compared. The combination therapy significantly prolongs PFS compared with TKI monotherapy in patients with L858R mutation, which did not translate into oral survival benefit, as you can see clearly depicted in this forest plot curve.
1 minute to conclude, please.
Yeah, so I will be quickly coming to a 60-year-old female patient. I will be putting a case with productive curve with good performance status. 3-centimeter nodule was there in the left lower lobe. Biopsy was adenocarcinoma, and there was no CNS symptoms. MRI picked up 2 brain lesions, and mutation was EGFR L858R. So patient was started on dacometinib by the data which we have listened on Archer 1050, 45 milligram OD. And reassessment scan was after 2 months, we showed objective response, and grade 3 diarrhea was the only side effect which was managed conservatively, and patient was continued with 30 milligram. Majority of patients, like in this trial also 66%, there was attrition because of the side effects. So as you can see, this good, we're having good CNS penetration also, all right? So this is what is depicted. There are so many multiple case reports which have shown that this drug is going to have a good effect in leptomeningeal carcinomatosis also. So I will quickly come to the safety summary. It is well tolerated. Majority times the side effects are diarrhea, dermatitis, stomatitis, and paranoia. If we use the attenuated doses, we can manage that very effectively. Asian population is having the leverage, and there are so many studies which I will be skipping right now. But only last thing I want to convey that dacometinib is a viable treatment option for EGFR mutation positive NSCLC based on the molecular and clinical data. EGFR 19 deletion and EGFR 21 mutations can be considered as 2 distinct subtypes of EGFR mutating drugs. Different EGFR TKIs have different role for EGFR 19 deletion and EGFR 21 mutations. Therefore, treatment strategies for EGFR 19 or EGFR 21 should be benchmarked on comprehensive analysis based on efficacy, safety, and quality of life. Last words of wisdom, that if we were not for greater variability amongst individual, medicine might as well be science, not an art. And he who studies medicine without books, sales, and uncharted sea, but he who studies medicine or medical oncology without patient doesn't go to see at all. Thank you very much for your patient listening.
Thank you, Dr. Nagendra, for such lovely presentation and the last quote also. So we all understand that, yes, sometimes the data shows certain things, but then when you do things in real life and you have patient experiences, then is when you realize that whether the drug is good or the drug has some foundations beyond a trial. So I agree with you, and I feel that yes, these are two subgroups which are should be treated differently, and over time we'll realize that certain subgroups will benefit from one TKI compared to the other one. So these things have to be known and understood in the clinical practice. So how do you treat your patients in your practice? Like, do you have this data? Like, how do you start your recommended patients? What is the drug at which you start?
Right. So right now, sir, we are discussing. We carefully look at the report whether is this uncommon mutation, if it is a common mutation. If it is common, then whether it is deletion 19 or L858R. Then we always open up that this is the way the science is unfolding. We always tell the patients that dacomitinib is having a leverage in Asian patients. It's having a wonderful response. Only thing is there are like 66% attrition rate was there when it was used in the trial itself, Archer 1050, because it's a toxic drug. So many times we have to use the attenuated doses, and majority of patients are doing well. Although we all know L858R carries poor prognosis, but can carefully studied patients, if we give this drug and monitor the side effects properly, I think we can do justice for our patient. And the law of oncology says that if we have to keep this patient as good as possible for as long as possible, isn't it? Thank you.
Thank you, Dr. Nagendra. And we move to the next presentation. And for that, I invite Dr. Manish Singhal. He's senior consultant and head of department at Indraprastha Apollo Hospital, Department of Medical Oncology. And he will be speaking on addressing the unmet needs in ALK.
रात को उठेंगे नहीं, नींद में गिर सकते हैं क्योंकि उससे थोड़ा सा चक्कर आता है.
Dr. Manish.
Hi.
Hi. हम उठे हुए हैं आपके लिए. So addressing the unmet needs in ALK treatment landscape, that will be what he will be speaking on.
Yeah. Can I request the slides to be shared from the end of the organizers or the backup team?
Aru, can you share?
I've already sent the slide set to them.
Okay.
Is my slides visible?
No, not yet.
Yes, sir. Yes, sir. Your slide is visible, Aru, sir.
In the management of ALK positive metastatic non-small cell lung cancer. Next slide. So we all know that ALK inhibitors have come of age as far as the treatment of lung cancer is concerned, and as such, lung cancer incidence is likely to increase in India, and it is following a very dreadful trajectory as far as the incidence is concerned. So is the mortality. Next slide. And still, I think we have not made much headway as far as early detection of lung cancer is concerned. We don't have any lung cancer screening program as exists in the Western world. And so we still have a very high mortality as far as lung cancer mortality is concerned. So most of the cases are detected in late stages. ALK rearrangement is present in about 7% of, and one of the most common after the EGFR mutation, and which is a targetable genomic change and makes them sensitized to ALK inhibitors. Next slide. The ballpark overall survival reaches almost about 7 years, and that's 81 months, and that's what is being produced from real world data, and that is quite reassuring and quite compelling as far as the use of ALK inhibitors are concerned in diagnosing non-small cell lung cancer with ALK mutation. Next slide. So typical clinical pathological features are minimal no smoking, adenocarcinomas, younger age, and lack of other mutations such as EGFR. Brain metastasis is fairly common, so it's very important and prudent to do a brain MRI upfront. And most of the ALK inhibitor studies include a brain MRI compulsorily. And the prevalence is about 7% in 5% in unselected, but in selected population, it may be around 7 to 8% also. Next slide. So this is the ALK inhibitor development timelines. It was detected in 2007. The first crizotinib, the first generation drug was launched in 2012 based on the profile studies. Then came the second generation, and that was usually after the failure of crizotinib, and then the first line usage of the second generation, and then came the third generation drug, lorlatinib, and then the first line usage of lorlatinib. Next slide. Next slide. Yeah, so these are the various the structures of various molecules, and we can see that there are subtle changes here and there, which makes them more CNS penetrable and also causes better efficacy and better efficacy against mutations. Next slide. So more activity, more potency, and better CNS activity. The profile 1001, which was the initial study, showed a remarkable overall response rate of 57% with the disease control rate of 87% in a pre-treated population with median progression-free survival of 9.7 months. Next slide. Then was the profile 1007 and 1014, which established crizotinib in the first line treatment as when it was pitted against chemotherapy in the first line treatment of ALK positive non-small cell lung cancer patients. And the ballpark figure for progression-free survival was about 10 months or 11 months. Next slide. So there were various other trials of second generation, such as the ASCENT trial. ASCENT-4 was ceritinib versus chemotherapy and not pitted against crizotinib, and that is one factor which one talks about ceritinib not been pitted against crizotinib. But the progression-free survival is definitely better than what is achievable with crizotinib. Alectinib has been pitted against crizotinib in the ALEX trial, and the median progression-free survival was a whooping number of 34.8 months. And so was with brigatinib, which hit a progression-free survival of around 24 months. So all these drugs were performing much better than what crizotinib performed. So they found their usage in first line. Next slide. So almost replacing crizotinib practically. Lorlatinib was a third generation drug, and its activity in the brain and activity against acquired resistance to ALK inhibitors has been well established now. Next slide. So it has activity against most of the mutations such as the G1202R, the F1174L, and so on and so forth. Only the L1196M is something which it is resistant to. And so these are important because there are a lot of mutations which can occur. And so it binds with a lot of affinity with ALK and has amazing CNS penetration. Next slide. So this is one paper from Tata Memorial, and which looks at the real world data and shows that lorlatinib does produce a remarkable response rate in a pre-treated population of about 50-60%. And with patient with brain metastasis, the response rate is around to the tune of 60%, which establishes that the drug has a very potent effect in the brain metastasis as in the systemic disease. Next slide. So it also depends on how do you sequence these drugs. So if you sequence these drugs with first line, then the second line, then the second generation, then the third generation, you're likely to encounter a lot of double mutations, including the more dreaded L1196M mutation, which is resistant to even lorlatinib. So it is important that the more efficacious drug is brought in early, because if you use a lot of sequencing strategies, which is something which has been argued upon, that one should sequence to get the best possible outcome. But the counter argument to that is that you're likely to encounter with more mutations, more tougher mutations, double mutations, triple mutations. And that is how you can lose out on the efficacy of the better drug in later lives. Next slide. So, there can be triple mutations as highlighted over here, and which can make the third line usage of a more efficacious drug less efficacious. Next slide. So lorlatinib, as the lines of previous TKIs improve or keeps on increasing, the efficacy keeps on dropping of lorlatinib, and so is the median progression-free survival, and that is what is highlighted over. Next slide. So the rationale of upfront use of a pan-inhibitory agent is that you're not likely to encounter more resistance, and perhaps you are able to get better and increase your progression-free survival and give the best drug. Same is the concept with osimertinib in first line, because it has proven that the overall survival was better. And very similar on the same note, the lorlatinib also holds true. Next slide. So this was a CROWN study, and of course the proof of the pudding is in eating. So this is the patient data and the clinical trial, the CROWN study, which was a 1:1 randomization between crizotinib and lorlatinib, 100 milligram OD versus 250 milligram BID, and the presence of metastasis, brain metastasis was allowed, and there was stratification based on ethnicity. The median, the primary endpoint was progression-free survival assessed by the independent review committee, and then there was a PFS by the investigator, overall response rate, overall survival, quality of life, etc. Next slide. Next slide. So these are the patient dispositions, and so we can see that these are quite well matched between the two groups, and nothing very highlighting over here. Next slide. And about 26%, 25% patients had brain metastasis. So the primary endpoint was met, and the progression-free survival was not reached, but at a 12 months mark, it was 39% versus 78%, which was almost doubling of the progression-free survival. And the median in the lorlatinib was not reached, and the hazard ratio is 0.28. Next slide. Which is by far the best. And if you look at the PFS by the investigator, it was 0.21. The hazard ratio is even better. Next slide. And this is the first plot, which basically dictates that all subsets are equally getting benefited. As a matter of fact, those with brain metastasis are benefiting even more. Next slide. So overall response rates are in the tune of 76% better than crizotinib, and there are few CRs, and the overall disease control rate is also better. Progressive disease is by far similar between the two arms, that is around 5%. Next slide. So this is the intracranial efficacy, and if you look at the intracranial efficacy, it is remarkable with lorlatinib. So patients with measurable bone metastasis, brain metastasis had almost 82% response rate, which by far is better than the 72% response rate, which is in the systemic disease. So 82% response rate in brain metastasis with those with measurable brain metastasis is certainly very remarkable, and the median duration of response is not reached versus 10 months with crizotinib. Next slide. So intracranial time to progression by the independent review committee, you can see that there's almost a straight line with lorlatinib. There's hardly any dip in this Kaplan-Meier, and whereas crizotinib does keep failing as the time progresses. Next slide. This is the overall survival, and we have a hazard ratio which favors lorlatinib, although not reached statistical significance because it's not yet mature. Next slide. So adverse events are I think we all understand these adverse events, and as far as the adverse events causing permanent discontinuation of drug was lesser with lorlatinib, not statistically significant, but it was lesser with lorlatinib, and it was not very different between the two drugs. Next slide. So these are the adverse events. We know that we got to use some form of statins whenever we are using lorlatinib, because it does cause the hypercholesterolemia. Next slide. Quality of life was better with lorlatinib as compared to crizotinib. Next slide. So in conclusion, lorlatinib resulted in a significantly longer progression-free survival, significantly higher overall and intracranial responses, and as such the intracranial responses was 82%, and with even complete responses which have been registered. And the safety profile calls in that both are well-tolerated drugs. And these results support the use of lorlatinib as an effective first-line therapy for patients with advanced ALK-positive non-small cell lung cancer. Next slide. And if you compare with the other agents, the hazard ratio with lorlatinib seems to be the best. It stands at about 0.28. As far as the investigator assessed progression-free survival is concerned, it was 0.21, which seems to be very, very reconciling. Next slide. And if you compare, if you put this data into context of comparing lorlatinib with alectinib and brigatinib, although these are not head-to-head comparison, but it's likely to give a hazard ratio of 0.54 or 0.59 when pitted against brigatinib and alectinib respectively. And in case they are untreated and ALK inhibitor naive population, again, it is likely to give a better hazard ratio as compared to. So these are projected hazard ratios. Next slide. So these definitely fetch a category 1 indication. Lorlatinib, brigatinib, and alectinib fetch category 1 indication in the NCCN guidelines. Next slide. And even in the ESMO guidelines, it highlights as one of the preferred indications for the use of alectinib, ceritinib, and brigatinib. Next slide. So overall dose interruptions as far as alectinib, brigatinib is concerned, it is lesser than the dose interruptions is lesser with lorlatinib, and overall discontinuation rate also seems to be slightly better with lorlatinib. So all in all, it seems to be a well-tolerated drug. Next slide. So this is the feasibility and challenges for sequencing, and of course this remains an open question, and these are various therapies and strategies which are getting evolved. Next slide. And the EML4 ALK, there's one variant where P53 co-mutation can coexist, and even in that population, lorlatinib is holding its gun well, and it's performing quite well, even with variants and as well as TP53 co-mutation. Next slide. So overall survival curves are here to be seen, and yes, the ALEX data seems to be slightly immature yet, but yes, the curves are separating, and it appears that lorlatinib is like with longer follow-up, lorlatinib curves are likely to separate even further. Next slide. So I think we can skip this. Next slide. So this is the final slide, and the progression-free survival, which remains the hallmark for drug approvals. And I think lorlatinib has definitely fetched the highest progression-free survival with a very impressive hazard ratio of 0.28, which seems to be better than with any type of second-generation ALK inhibitor. Next slide. So, so this is my final concluding slide, that the results seem to favor lorlatinib over other ALK inhibitors, but one is free to sequence them. But sequencing may be fraught with more resistant population, which may make the third generation lorlatinib less effective in later lines of treatment. Next slide. With that, I thank you, and over to the organizers.
Thank you, Dr. Manish, for such comprehensive review of the ALK landscape and ALK landscape, how it is evolving. So, my question is there some data with respect to this hyperlipidemias? Do they have any adverse cardiovascular impact upon that patient, because the patient will live for next 4 to 5 years, and they are mostly elderly people? So is there some information or take on this?
So I think what is important is that you need to be aware of the hypercholesterolemia, and if it remains unchecked, and if there is a patient who is already at high risk, definitely it calls in for intervention. And if you are aware of, if the treating physician is aware of hypercholesterolemia, it can certainly be controlled with simple drugs. So it should not come in the way of using lorlatinib.
Okay. So thank you so much. And we have been running like 10 minutes late, so I hope that we keep on the track. Thank you, Dr. Manish, again, for such lovely presentation.
Pleasure.
And now we move to the next presentation. The next presentation will be, actually I'm going to have the next presentation. I'll be speaking upon, can I have my presentation slides put up? So the topic I'm going to do is the role of atezolizumab in the first line metastatic non-small cell lung cancer. So how there's one drug which has evolved over time, and now it's one of the important, I would say, one of the important pioneers into managing first-line patients, especially when we are dealing with certain difficult patients. Okay, so we now know that the landscape of lung cancer has been evolving, and we have 3 landmark studies from for atezo. So we have IMpower 110, we have IMpower 150, and we have 130. So these are 3 studies, and what we have learned over time is that these patients will be rapidly evolving, and there are certain patients, there are certain clinical criteria where the immunotherapy might actually have a benefit over only chemotherapy and or targeted therapy. Next slide. So I just skipped this because we have been running late, and the landscape has been evolving post 2015. Cancer immunotherapy has become important part of lung cancer management, and especially checkpoint inhibitors. Next slide. So we now know that the lung, if we just see the molecular landscape, so we just had 4 pies in 2000s, and now we have the pie split into almost 28-30 different slices, where we have one important fascinating area will be KRAS, and I think next 2 years we'll have a lot of KRAS inhibitors coming into the picture, and more of targeted drugs in that arena becoming a part of the treatment. But before that, we have EGFR, ALK, ROS, MET, and the other ones are, the rare ones are HER2, BRAF, and PIK3, and there are still a lot of them where there's no mutation or uncommon mutations or kind of a high tumor mutation burden, no specific mutation which is driving the tumor, and such are the tumors which are more likely to be immunogenic. And what has been found is that with respect to targeted therapies, if we just compare it to chemotherapy, so if we just see the patients who have been receiving some form of targeted therapy, the immunotherapy or chemotherapy, if we just see the data, the collected data, the OS has almost the difference of tripling of the data. So if we just compare to chemotherapy, the median survival is 12.7 months, whereas with targeted therapies, the survival is reaching around, median survival is reaching around 31.8 months. Whereas only with the supportive care, these patients are unlikely to survive even 6 months. So there has been a lot of change which has happened over the last 2 decades. Next slide. So now if we go to global phase 3 data with atezo, so we have the IMpower 110 trial, which was a trial which had both non-squamous as well as squamous, and the question which I answered was, is atezo monotherapy a better agent than chemotherapy in PD-L1 selected chemotherapy naive patients? So could we just avoid chemotherapy in first-line patients? This is the question which IMpower 110 answered, especially in patients who were positive for PD-L1 by SP142, at least with combined scoring of or PC or IC score of at least 1 or more. So that was the first trial. I'll go to this trial in more detail sometime. Then the second trial, which was kind of a practice-changing trial when it came, so it has still remained as one of the options in the upfront setting of patients where the non-squamous patients which were randomized to either atezo plus pacli plus nab-pacli plus carbo versus only nab-pacli plus carbo. The question was whether steroid-free chemotherapy along with atezo could be one of the important aspects of treating such patients. If we have to combine immunotherapy with chemotherapy, we would like that chemotherapy to be steroid-free. The third important trial was IMpower 150, and where we had combination of bevacizumab along with atezo. So whether a 4-drug combination, whether a 2+2 combination, 2 immunotherapy and 2 chemotherapy, whether that could be better than any other single immunotherapies, and it had 3 arms which were randomized equally to 3 subsets. So these 3 trials I'll go through. Next slide. So coming to IMpower 110, it had both the squamous and non-squamous, and the question answered was whether immunotherapy alone can replace chemotherapy in patients who are PD-L1 intensified. Next slide. So it was a randomized phase 3 data, randomized 1:1 to these two arms. And the choice of chemotherapies were in non-squamous were pemetrexed with cisplatin or carboplatin, and squamous it was gemcitabine with cisplatin or carboplatin. And atezo was continued till disease progression or loss of clinical benefit. And the patients selected were which were ALK or EGFR negative, and all other patients who were PD-L1 selected. PD-L1 selection means that the patient had to have at least TCIC score of 1, 2, 3, and that minimum had to be less than more than 1% with SP 142 IC assay on Ventana. Next slide. So if you just compare in the total population, if you just see in both arms, the TC or IC3 patients were around 35% patients, TC2 or 3 were around 60% patients, and the total population amongst TC1 or IC1 will be rest of around like 10%. The total population had most of the patients were either TCIC2 or TCIC2 IC3. So this was the kind of population it was. Next slide. Next slide. So both the arms were well randomized for age, the sexes, white, Asian, non-Asian, never used tobacco. So the baseline characteristics were well matched in both arms. Next slide. Now, if you just see the overall survival, so if you compare overall survival in the patients which were only on chemotherapy, the median overall survival was 13.1 months. Now, compared to 13.1 months, the overall survival was markedly improved in the atezo arm to 20.2 months. Hazard ratio was 0.59. So the primary endpoint of OS in the PD-L high subgroup was met in this trial. So this was a clinically positive trial and also statistically significant trial which meaningfully improved the overall survival in the PD-L1 enriched population. Next slide. And if you just see, most of the hazard ratios were favoring the atezo arm compared to chemotherapy. Though in the elderly population, which were beyond 75 years of age, or patients who were never used tobacco, it was favoring chemotherapy. But rest all the hazard ratios were in the favor of atezo arm. Next slide. So also patients who had received atezo, the further lines of treatment could receive. So patients who had already received atezo, they kind of could receive chemotherapy in the later lines and could also be given targeted therapy in later lines. Next slide. Now, if we just see the selected population of TC or IC3 population, the PFS data, if we just see compared to only chemotherapy. So chemotherapy, the survival was only 5 months, and the median PFS was 8.5 months. So 8.1 months in the TC3 IC3 population compared to only 5 months in the chemotherapy, which meant that the more the degree of expression of PD-L1 either on tumor cells or on the immune cells, the higher the chance the patient would have benefit in this subpopulation. Next slide. If we just compare the response rates were also much higher. So it was 38.3% compared to 28.6% in the chemo arm. So higher number of patients responded in the TC IC arm, and also the duration of progression-free survival was much longer in the TC IC arm compared to chemotherapy with respect to atezo. Next slide. The safety profile was in favor of immunotherapy. Most of the patients tolerated the immunotherapy well, and if you just see, the chemotherapy fared worse compared to the immunotherapy. Next slide. Just see the bar diagrams. The most of the side effects happened in the chemotherapy where nausea, vomiting, neutropenia, constipations were much higher, though some immune-related side effects like increased ALT or AST, pruritus, and hypothyroidism were more in the atezo arm due to immune-related side effects. Next slide. To summarize, atezolizumab represent the promising first-line treatment options in PD-L1 high non-small cell lung cancer patients, but we have to understand that these are the patients who have been checked with SP142. So that's very important, especially when you're choosing such patients. And it was a positive study which demonstrated significantly and clinically meaningful improvement in the OS in the TC or the IC3 wild type population versus the platinum-based chemotherapy, hazard ratio of 0.59. The safety profile was in favor of atezo compared to chemotherapy, and a patient had longer exposure to the drug when compared to chemotherapy, and the patient could benefit on a longer duration with atezo. Next slide. So now coming to the second study, which was IMPA 150. It was a phase 3 study of atezo plus chemotherapy plus bevacizumab in first-line non-small cell lung cancer. So this was one there. I would say logic of having a very antibody along with a PD-1 antibody, the dual antibody blockage along with a dual platinum-based was used, and so there were 3 arms. So the experimental arm was the 4-drug arm, which was atezo paclitaxel, and it was compared to either atezo paclitaxel or paclitaxel. For instrument I mentioned last trial, more than 1,200 patients enrolled, and the patients, the stratification was with respect to ideal PD-L1 expression and liver metastasis, and all these patients were chemo-naive. So immunotherapies were continued till disease progression, and in the arm B, both the drugs were continued till unexplainable toxicity or disease progression. Next slide. The primary endpoint was PFS as well as OS. Next slide. This we know. Next slide. So baseline characteristics were well matched in all the 3 arms. The one important aspect was that 14% of patients had liver metastasis at baseline in almost all the 3 arms, and 10% of patients also had EGFR mutations, which are positive, which is well balanced in all the arms. And also there was a 50-50% split with respect to PD-L1 positive as well as negative patients, if we just see. So these are the various stratification factors which made us understand, because it was a large trial with more than 1,200 patients. These subgroups also had an important meaning when we try to dissect this study. Next slide. So now coming to the first endpoint, which was the OS. So if we just see, if we compare the arm B versus the arm C, so arm B was all the 4 drugs, and if we compare to the arm C, so just see the overall survival at 12 months was 67% versus 61%. At 18 months was 53% versus 41%, and at 24 months was also 43% versus 34%. Hazard ratio was 0.80, which was both statistically as well as clinically significant in favor of the 4-drug combination. Next slide. So if we now see with respect to all these 3 arms, the objective response rates. Now, if we just see all the intention to treat population, again, the arm B was significantly higher with respect to objective response rates. Now, if we just see in the PD-L1 TC3 or IC3 population, the arm B still scored better compared to arm A. So arm A did better with respect to arm C. So arm C was the most inferior arm, but still the 4-drug combination could even enhance the PD-L1 positive population, which was only treated with atezo, to have higher response rates. Similarly, even in the low group, the 4-drug combination did better than only the single immunotherapy arms. Even in patients who were TC or IC negative. Now, if you see the TC or IC0, arm is poor compared to chemotherapy to their arm. So, which showed that a combination of TC0 IC0 should not there might not be any benefit, but any positivity in the form of TC or IC1, 2, 3 are patients who will benefit with atezo, and additional bevacizumab to atezo might actually have a supradditive effect with atezo with the chemotherapy alone. Next slide. Next slide. And this shows with the proof. Can we go back one slide back? So this also shows that in the PD-L high, which were TC or IC3 patients, the overall survival curves separated very early on, and they continued to have a benefit. So difference was 25.2 months versus 15 months in the high PD-L1, and when we compared in the TC0, IC0, in fact, there was not much benefit, and the curves were almost at the same level. Next slide. Now coming to specific subgroups. So EGFR positive patients, even we know that almost 10% of population was EGFR positive in all the three subgroups. So when we see these patients which were included, if you just see these patients, whether these patients with respect to chemotherapy, how would a 4-drug combination have a benefit role? So these were chemo naive, but they could be exposed to prior EGFR. So beyond EGFR, what next? I think that is a question which we need to answer. So go to the next slide, please. So we could find that if the 4-drug was used and only compared to 3-drug, there was a hazard ratio 0.59 with respect to the 3-drug combination. So we found that there was a huge difference of 9.7 months versus 6.1 months. So there was a benefit which happened in even this population, which otherwise would not be expected. Next slide. Next slide, please. So, and also we found that there was a difference of in the OS. So OS also was benefited in arm B versus arm C, hazard ratio 0.60. Next slide. Next slide. And so was the objective response rates and duration of response in this subgroup compared to the single agent BEV with the chemotherapy. Next slide. Also in the population with liver metastasis. So if you just see the patients who are liver metastasis, they fare badly compared to their other subgroups. And here also we could find that chemotherapy plus BEV was only 5.4 months, whereas the 4-drug combination did very well. With the median survival was increased to 8.2 months, and the hazard ratio was 0.41. So these are all the subgroups where we find where we can have a role for patients, especially the EGFR positive patients. If they are progressing, they are PD-L1 positive, how to have the next line of treatment, whether we should have 4-drug combination or we can only give chemotherapy. So I think that is where we have a role of atezo plus BEV plus 2-drug combination. Also patients with liver metastasis, rapidly progressing disease. Such patients are likely to benefit with 4-drug combination compared to only going for chemo plus BEV. Next slide. So also there was an OS benefit which was observed in this arm, and we could find that the median OS improved from 9.4 months to 13.3 months. Next slide. Next slide. Can you go to the next slide, please? So was objective response rate and the duration of response. The objective response rates were on the tune of 60.8% compared to only 41.5%, 41.1% in the BEV plus chemotherapy arm. So the duration of response also doubled in the patients who were given 4-drug combination. Next slide. Also, patients with bulky disease similarly benefited. Next slide. In the interest of time, can we just go to the next slide, please? Yeah. Next slide. So if you just see the patient with high tumor burden compared to patient with low tumor burden, survival as well as the objective response rate are much higher in the patients with high tumor burden with respect to low tumor burden. So patients who had high tumor burden were more likely to benefit with the 4-drug combination compared to the 3-drug combination. Next slide. Next slide. So there was a high proportion of treatment-related adverse events, especially the adverse events they were put us, so it was expected, but then all side effects were well managed. Next slide. So the conclusions of IMpower 150 was that it was a positive study in the first-line non-squamous small cell lung cancer, which statistically and clinically improved both the primary points of OS and PFS for the 4-drug combination of atezo plus BEV plus CP compared to only BEV plus CP arm. The clinical benefits were observed in the key subgroups of patients with EGFR ALK, genomic alterations, liver metastasis, and bulky disease. And these are the patients which will benefit from the four-drug combination. Atezo combination with chemotherapy with bevacizumab is well tolerated and safety is concerned with known safety risk, and addition of patient capacity beyond PD-L1 expression may be considered when making chemotherapy decisions for non-small cell lung cancer patients. Next slide. I just briefly rush through the IMPA 130 in the interest of time. Next slide. Next slide. So it was a phase 3 of nab-paclitaxel with carboplatin with or without atezo the first time, and this was a kind of a try to find whether a non-steroidal combination of chemotherapy could work better with atezo. Next slide. Next slide. Next slide. So this was the trial schema. Can we go to the next slide? Next slide. So the co-primary endpoints were PFS and OS, and both the arms were well matched with respect to the age as well as sex, liver metastasis, bone and racial as well as ECOG performance status. Next slide. So if you just see the progression-free survival, so in the atezo plus chemotherapy arm, so the hazard ratio was 0.64. The 6 months PFS was 56.1%, 1% was 42.5%, and at 20 months was 29.1% versus 14.1%. So this was a landmark 12-month PFS, which was doubled with the addition of atezo to only nab-paclitaxel plus carbo. So this was, and you can just see the separation of curves were very clear. So there is a population where addition of atezo could be actually beneficial, especially if we go for right kind of chemotherapy, and this could add to the benefit of chemotherapy. Next slide. Next slide, please. So if you just see the subgroup analysis, almost all the subgroups benefited in the 3-drug combination compared to only chemotherapy. Next slide. So so now if you see there was no PFS or OS benefit with observed chemotherapy alone in EGFR or ALK positive patients. So IMPA 150 is the only phase 3 study which have demonstrated clinical benefit of chemotherapy in this setting, which I think there's one takeaway from all these 3 trials. Next slide. So if we just see both objective response rate as the PR as the stable disease rates were higher in the 3-drug combination compared to only chemotherapy. Next slide. Next slide, please. So side effects were well matched and were well tolerable. Next slide. Next slide, please. So the key conclusions were, it was again a phase 3 positive trial and demonstrated significant clinically relevant OS benefit in the atezo plus nab-paclitaxel arm. And it demonstrated a higher PFS and a higher ORR would benefit the patients. And the OS and PFS benefit was across all key clinical subgroups except in the EGFR ALK positive patients. And atezo plus chemotherapy has a manageable safety profile. So with this, I'd like to thank you. Next slide, please. So the key message of this is that atezo plus bev could be one of the important contributors, especially in a subset of patients where they are PD-L1 expressing patients, they have bulky disease, they have got a liver metastasis, or they are patients who are initially EGFR or ALK positive and now have progressed on the TKI. So with this, I'd like to close my session, and now I'd like to invite Dr. Jyoti Wadhwa. Dr. Jyoti Wadhwa, ma'am is Director Medical Oncology and Hemato-Oncology at Medanta Hospital, and ma'am will be speaking on moving the needle from PD-L1 to PD-L1 negative tumors. Over to you, ma'am, for your talk.
Thank you, Dr. Sajjan. Please allow me to share my screen.
Aru, ma'am, help ma'am to share her screen.
Yes, ma'am, you can now share your screen.
I'm able to, yes. So are my slides visible now?
Yes, ma'am.
Yes, ma'am.
Okay. So good evening, everyone, and very interesting topic for discussion now, focusing on PD-L1 negative metastatic non-small cell lung cancer in terms of its management. And this is sponsored by MSD, and these slides have been provided by them. So we all know that globally, lung cancer is the leading cause of cancer deaths in both men and women. It is also the second most commonly diagnosed cancer as per Globocan 2020 data. And non-small cell lung cancer continues to be the commonest subtype, accounting for 84% of all lung cancer diagnoses. Now in India also, lung cancer is quite prevalent. It's the fourth highest in terms of cancer incidence and cancer mortality. And in fact, if you compare the Globocan data of 2018 and compare it with more recent 2020 data, you would notice an increase in numbers. The mortality seems to be stabilizing now with improvements in the treatment. Now we know that there is a correlation between the biomarker PD-L1 and immune checkpoint inhibitors. Though we also know that this is not the gold standard and this is not a perfect biomarker, because we are aware and we have experienced in our practice that even those patients who are PD-L1 negative do experience a benefit with immune checkpoint inhibitors. So this is the largest real-world study, a global multi-center study, which reported the tumor PD-L1 prevalence in the real world. And this reported the results of PD-L1 tumor expression based on 22C3 platform. And if you notice, the proportion of patients who have TPS score of 50% or greater, a TPS of 1% or greater, and even those who have negative PD-L1, that is less than 1% TPS, across the globe, the prevalence, the proportion of these three subcategories seems similar. So the prevalence of these three different subgroups is similar across the geographic regions overall, and also in those who tested negative for the driver mutations, namely EGFR and ALK. No significant variation in the PD-L1 expression was seen also in those who were treatment naive and even in those who were previously treated patients. So if you notice here, based on the Keynote 001, 010, and 024, the PD-L1 TPS seems similar across these different subgroups. Now, when you try to see the proportional distribution of different populations of PD-L1 expression, the age doesn't seem to affect the distribution, whether the patient is less than 75 years of age or more than 75 years, whether you test it in the primary or in the metastatic site, and whether the histology is squamous or non-squamous or even unknown, the proportional distribution of PD-L1 expression subgroup seems to be similar. Now, this is a very landmark trial, the Keynote 189, the results of which were published in NEJM 2018 and also presented in the World Lung Cancer Congress in 2020. This trial earned Keytruda or pembrolizumab its approval for first-line treatment of metastatic non-squamous non-small cell lung cancer in combination with chemotherapy. Very interesting, very robust trial, very well conducted trial, including 616 patients with stage 4 non-squamous non-small cell lung cancer with measurable disease. Patients had to have no detectable EGFR or ALK alteration, had to be in good performance status. Prior use of any immune checkpoint inhibitor was not permitted, and they had to be treatment naive. The tumor tissue was tested, and the life expectancy had to be at least 3 months before enrollment into this trial. And obviously, they could not have had any contraindication to the use of immunotherapy, pembrolizumab. So patients were randomized 2:1 into an arm, which consisted of pembrolizumab with pemetrexed, with carboplatin or cisplatin, all in standard doses for 4 cycles. This was followed by maintenance with pembrolizumab and pemetrexed, again in standard doses, till progression. The other arm consisted of placebo with PEM with platinum, again in the standard dose of chemotherapy, followed by PEM maintenance. Now, the stratification factors in Keynote 189 were PD-L1 expression. The level of PD-L expression was stratified as less than 1% or 1% or greater. They were also stratified as to what platinum agent they received and whether they were never smokers or former or current smokers. The primary endpoint of this trial, Keynote 189, was progression-free survival and the OS, overall survival. Secondary endpoints being the safety of the treatment, the overall response rate, and duration of response. PFS2 was another exploratory endpoint of this study. So this curve shows the 4-year follow-up of overall survival in the intention to treat population. You notice here that the patients who received pembrolizumab along with chemotherapy had median OS of 22 months compared to almost half, 10.6 months in the placebo with chemotherapy arm. Furthermore, at end of 2 years, 45% of patients were still surviving in the pembro with chemo arm versus only 27% in the chemo alone arm. At 3 years also, this separation and differential benefit of pembrolizumab with chemotherapy was maintained, 31% of patients being alive at end of 3 years. Now, when the segregation was done as per the PD-L1 TPS score, there were 3 groups, TPS of 50% or greater. In this subgroup, the median OS in the pembro with chemo arm was an impressive 27.7 months versus 10 months in the chemo arm, hazard ratio being 0.71. So 29% reduction in the risk of death in favor of pembrolizumab with chemotherapy arm. In the group of patients who had TPS of 1 to 49%, again, 21.8 months median OS in the pembro with chemo arm versus 12 months in the chemo alone arm. Hazard ratio, again, being an impressive 0.66. Now, focus your attention to this third subgroup, TPS less than 1% or PD-L1 negative subgroup. In this, you notice that the median OS was 17.2 months in the pembro with chemo arm, and in the chemo alone arm, it was 10.2 months, hazard ratio of 0.52. So 48% reduction in the risk of death, even in those who had PD-L1 of less than 1%. Now, what about the progression-free survival? So 4-year follow-up of PFS in the intention to treat population shows that the median PFS was 9 months in the pembro with chemo arm compared to 4.9 months in the chemo alone arm. And again, the differential benefit in favor of pembro with chemo at 2 years, 22% versus only 4% in progression-free survival. And the difference is maintained even at end of 3 years, 11.8% of patients being progression-free in the pembro with chemo arm versus just 1% in the chemo alone arm. So again, hazard ratio of 0.50 in favor of pembro with chemo arm. Now, again, segregation, stratification based on the TPS, PD-L1 TPS. The patients who had TPS of 50% or greater, you notice here that the median PFS is 11 months versus 4.8 months. In those with TPS of 1 to 49%, again, the differential benefit in favor of pembro with chemo. Also, in the patients who tested negative for PD-L1, there is numerical difference of median PFS, 6.2 months versus 5 months in chemo alone arm. The hazard ratio here again is 0.68. So there is some difference there as well. Now, what is the other evidence? We learned in Keynote 189 about the non-squamous histology. Now, what is the evidence in squamous histology? So the answer is in the Keynote 407 trial, another phase 3 study of use of carboplatin with paclitaxel or nab-paclitaxel with or without pembrolizumab as first-line treatment for stage 4 squamous non-small cell lung cancer. So again, stage 4 untreated treatment-naive patients with metastatic squamous non-small cell lung cancer in good performance status with the controlled brain mets were randomized now 1:1 to receive either pembrolizumab with Pacli or nab-pacli with carboplatin 4 cycles, followed by pembrolizumab maintenance up to 31 cycles, the other arm being placebo with the same chemotherapy protocol 4 cycles, followed by no maintenance or placebo maintenance. And the patients were followed till progression, when the crossover was permitted to pembrolizumab arm in the patients who received only chemotherapy as first line. So again, these stratification factors, just like Keynote 189, were the degree of PD-L1 expression, whether it was less than 1% or 1% or more. The choice of taxane was another stratification factor, and the region, Eastern Asia versus rest of the world, was also included as a stratification factor. The primary endpoint was again similar to Keynote 189, being PFS and overall survival. So this Keynote 407 trial, this is the overall survival. You notice here that the median OS is 17.2 months in the pembro with chemo arm versus 11.6 months in the chemo alone arm. The hazard ratio is again 0.71. At end of 2 years, again, greater proportion of patients in the pembro with chemo arm, and at end of 3 years also, a much greater proportion of patients, 29.7% versus 18% in the chemo alone arm, were still alive. So overall survival clearly showing a benefit with the addition of pembrolizumab to the chemotherapy. What about progression-free survival? Again, the median PFS was 8 months versus 5 months, 8 months in the pembro with chemo arm, and the differential benefit clearly in favor of pembro with chemo arm at 1 year, maintained at 2 years, and even at end of 3 years, the differential benefit is maintained with the addition of pembrolizumab to chemotherapy. Now, again, the segregation was done both for OS and PFS in the subgroups, PD-L1, 1% or greater, and also in those who had TPS score of less than 1%. So again, you notice that the overall survival median 18.7 months versus 12.8% months in PD-L1 expressing patients. And even in those who had TPS of less than 1% PD-L1, the median overall survival was 15 months versus just 11 months, again in favor of the combination of pembrolizumab with chemotherapy. Now, PFS also, the median PFS is superior. The difference is more when the PD-L1 was positive, but there is some difference, the hazard ratio being 0.68, even in PD-L1 negatives. Now, besides these two, do we have any additional data sets supporting the use of pembrolizumab with chemo combination in PD-L1 negative for first-line treatment of metastatic non-small cell lung cancer patients? The answer is again yes. We have exploratory pooled analysis from a prior conducted phase 2 trial, Keynote 021, the G subgroup of that, the Keynote 189 and Keynote 407. So there is a pooled analysis from these 3 trials. So this was conducted, and if you notice here, focus your attention to the table there. We have Keynote 021, the cohort G subset of patients who had no PD-L1 expression, and the Keynote 189 and Keynote 407, the subset of patients who had PD-L1 less than 1 were selected. So this was, these pooled analysis was conducted to in fact better understand the outcomes with the combination of pembrolizumab with chemotherapy in those patients who had PD-L1 TPS of less than 1%. And obviously we know that this subset of patients is not eligible for pembrolizumab monotherapy. And obviously they had to have no EGFR or ALK alteration. So across the study population, there were 1,328 total patients in these 3 trials. Of these, 444 patients had PD-L1 negative status. The 256 patients belonged to the arm which received pembrolizumab with chemotherapy, and there were 188 patients who received only chemotherapy. And almost everybody, so 256 in this cohort of pembro with chemo were evaluated for efficacy and 255 for safety. And similarly, 188 patients, so all patients were eligible for evaluation for efficacy in the chemotherapy alone arm, and 186 for safety. So again, to note here is that 54% of patients did receive subsequent therapy if they had earlier received pembrolizumab with chemotherapy, and 64% of patients who initially received only chemotherapy did go on to receive subsequent therapy. So if you compare the 2 group of patients in the PD-L1 negative group of the pooled analysis, you notice that they seem to be quite similar. The median age is similar. The proportion, the gender distribution is similar. The elderly, non-elderly distribution is also similar, and so is the distribution of performance status. In the pembro with chemo arm, the non-squamous histology was the predominant one versus predominant squamous histology in the chemotherapy arm. But otherwise, for rest of the characteristics, they were well matched in terms of especially distribution of brain mets or liver mets or the previously received treatment. Now, pooled analysis of patients of this PD-L1 subset for overall survival again favors the combination of pembrolizumab with chemotherapy for overall survival. The median OS being 19 months in the pembro with chemo arm versus 11.4 months in the chemo alone arm. The hazard ratio is 0.63. And again, as noted earlier in the pooled analysis of these 3 trials, also the difference is in favor of pembro with chemo, not only at end of 1 year, but also at end of 2 and 3 years, and the difference is significant. Now, if you see the subgroup analysis for the overall survival, you notice that all these dots are towards the left, signifying that pembro with chemo combination does perform better in all ages, both in men and women, irrespective of the region, whether the patients were from East Asia or they belong to rest of the world, and whether the patients had squamous histology or non-squamous histology, irrespective of their smoking status, irrespective of presence or absence of brain mets or liver mets. All these subgroup of patients did better when the combination of pembro with chemotherapy was used. What about progression-free survival? Again, median PFS 6.9 versus 5.8 months in the PD-L1 negative subgroup. What about the PFS2? So interestingly, the PFS2 was also better in the group of patients who received pembrolizumab with chemotherapy, 14.5 months versus 9 months in the chemotherapy alone arm, the hazard ratio being 0.57. Now, what about the overall response rate? So as I said, this was secondary endpoint in both the earlier phase 3 trials. So you notice here that the overall response rate was better, 50% in the pembro with chemo arm, and it was only almost 30% in the chemotherapy alone arm. The duration of response was also superior in the pembro arm to the tune of 8.5 months versus 6.9 months in the chemo alone arm, and both the subgroups though had some ongoing responders. What about the adverse events? So you notice that any adverse event happened to similar proportion, almost 99% had some adverse event reported, including infusion reactions, the immune-mediated adverse events. Obviously, I'll come to that in a bit. The common side effects, all cause adverse events reported in 20% or more as expected, and we all have experienced in our practice anemia, some nausea, vomiting, and some cytopenias, alopecia. They were all seen similarly in the two groups. The immune-mediated adverse events obviously were peculiar to the pembrolizumab with chemotherapy arm, and we know that we have to be alert to be able to pick them up early and manage them successfully. Now, the next question is, do we have a similar data analysis for Asian PD-L1 negative first-time metastatic non-small cell lung cancer patients? And the answer is again, yes. As I mentioned earlier, that in the previously reported analysis of pooled analysis, there was a subset of patients. They did categorize them whether they belong to the East Asia or rest of the world. And this is that presentation which was presented in ESMO Immuno-Oncology Congress last year, and pembrolizumab plus chemo versus chemo in Asian patients with PD-L1 negative non-small cell lung cancer, pooled analysis of the three trials, Keynote 021, 189, and 407. So again, you notice here that the two groups of patients were well matched in terms of various variables. Overall survival here in Asian patients also in favor of the combination of pembro with chemo, 21 months versus 12 months, again in favor of the combination. The significant difference is seen at 1 year, 2 year, and also at end of 3 years. At 3 years, 33% of patients are alive in the pembrolizumab arm versus 19% in the chemo alone arm. PFS, again, the median PFS 8.4 months versus 6 months in favor of pembro with chemo arm. And PFS2 was in fact significantly better compared to PFS1 in favor of the pembro with chemo arm. What about the overall response rate? Again, significantly better when the combination of pembro with chemo was used in the PD-L1 negative subgroup of Asian patients, 71% overall response rate versus only 43% with chemotherapy alone arm. The median duration of response being 6.7 months in the pembro with chemo arm. What about the adverse events? Again, they are similar to what I've already shown in the pooled analysis. Nothing different here. Again, the immune-mediated adverse events and infusion reactions are similar as expected, nothing new there. So to summarize, pembrolizumab plus chemotherapy provided clinically meaningful benefit when compared to chemotherapy alone in this pooled analysis of PD-L1 negative, advanced or metastatic non-small cell lung cancer, both squamous and non-squamous. Pembrolizumab plus chemotherapy did prolong overall survival, the PFS and PFS2 versus chemotherapy alone. The overall response rate was also higher with pembrolizumab with chemotherapy versus chemotherapy alone, and the similar benefits have been observed and reported in East Asian patients analysis as well. Furthermore, not only in terms of efficacy, the combination scored, but also in terms of safety, because pembrolizumab with chemotherapy had manageable safety in these patients. So these results are consistent with the global phase 3 studies and support continued use of pembrolizumab plus chemotherapy as a standard of care therapy in patients with non-small cell lung cancer without EGFR ALK alteration, regardless of PD-L1 expression. So I would end my talk here, and thank you, Dr. Sajjan, and thank you, MST.
Thank you so much, ma'am, for such elaborate talk on how pembrolizumab has been evolving from just affecting the PD-L1 positive patients to across all patient populations, and especially having a great benefit in the Asian population too. Ma'am, just want to ask one question. Is there some data where they've also tried to do some pool analysis with respect to the PD-L1 negative patients being high on TMB? So is there some data which is available, or?
No, TMB was not part of any of these analyses, in fact. Maybe another study is ongoing, but it wasn't, one of the study factors in any of the reported trials.
So the other issue is, was there a mention like why these PD-L1 positive patients are likely to benefit with the addition of pembro in such patients? Though we understand that the magnitude of benefit is not that great, but yes, even PD-L1 negative patients benefit. So is there some possible reason? Because there's been one mention that, okay, MSI high tumors are likely to have kind of an immune response. PMB high patients have such kind of, but why such patients are responding? So are there some other off-target effects of pembrolizumab?
So I think the reason still lies in the fact that PD-L1 is not a perfect biomarker. There's something beyond PD-L1 that may not be known to us as yet. But we have all experienced, isn't it, in our practice, good responses and even good survival in even those who are PD-L1 negative. So I think that's the answer. Research must go on.
Thank you so much, ma'am. Thank you so much for this lovely presentation. And now we move to the last session for today evening, and that will be by Dr. Devrat Arya. So Dr. Devrat Arya is Director of Medical Oncology at Max Saket, and he will be speaking on the role of Atezo in small cell lung cancer, the IMpower 133 study, and the new standard of care for patients with extensive stage small cell lung cancer. So I have Arun here.
Yeah, good evening, and many thanks to the organizers for inviting me to give this talk today. And over the next 15 minutes or so, the mandate given to me is to talk about the IMpower 133 study, which actually established Tecentriq plus chemotherapy in first-line extensive stage small cell lung cancer as the standard of care. So these are the various aspects that I'll try and cover in my talk. So I'll briefly talk about small cell lung cancer, its incidence, prevalence, the treatment guidelines, the various options, how treatment has had an unmet need for a significant amount of time, and how the advent of immunotherapy, and particularly atezolizumab, is actually to a large extent changed outcomes, improved outcomes for these patients. So we all know that small cell lung cancer is a very fast growing tumor. Doubling time is nearly 2 months. Overall response rates can be very high to first line therapy, but there are very limited second line options. Patients can develop early metastasis. In fact, 72% of patients present with metastatic disease. Mean age is high at 65 years, and significant number of patients present with tumor related symptoms. Majority of these patients are smokers, and unfortunately, despite the advances in lung cancer overall, there are no targeted therapies as yet in small cell lung cancer. Now, small cell lung cancer accounts for about 13 to 15% of all lung cancers. The 5-year survival rates are very dismal at around 2%. So how do we stage small cell lung cancer? I think the traditional classification has been the Veterans Affairs lung cancer classification, and they have typically divided small cell lung cancer into small stage, the limited stage or extensive stage. Limited stage refers to patients who can be treated with radiation therapy, where the disease is actually encompassable in one radiation field, and then the extensive stage disease, where the disease is not confined to one area which can be encompassed in a radiation field, and therefore is typically treated with systemic chemotherapy. Now, majority of patients, as I said earlier, even in the West, present with extensive stage disease. So nearly 2/3 of Western patients with small cell lung cancer present with extensive stage disease. And we talk about Indian data. I think nearly 3/4 of our patients present with extensive stage disease. So what are the treatment options? As I said, for limited stage disease, predominantly the treatment options are concurrent chemotherapy along with radiation therapy. For the isolated few patients who had node negative disease, very small primaries, surgery may be an option, but most of these patients end up receiving adjuvant chemotherapy and radiation therapy if node positive. For extensive stage disease, for a long period of time, platinum-based chemotherapy has been the standard of care. Most of these patients would end up receiving PCI to the brain, even in the absence of brain mets, because it has been shown to, at least based on the older studies, to improve overall survival. Now, the problem with small cell lung cancer has been the minimal progress that has been made in the treatment landscape. And I think since 1990s, the standard of care has been platinum etoposide. So most of the clinicians have used cisplatin or carboplatin with etoposide based on the data to show that the two drugs combined together work better than a single drug. The data also showed that the older formulations of CAV, that is cyclophosphamide, anthracycline, and vincristine, carbo-etover or cis-etover, nearly equivalent in terms of response rates. There has been a lot of interest around adding more agents, but unfortunately 3 or 4 drug regimens have failed to add to benefit. Maintenance chemotherapy has failed to add benefit. There has been some studies, particularly the JCOG study, which actually looked at cisplatin irinotecan, which while initially did reveal that there was some advantage, later on in the Western studies, at least, it showed that the regimen was probably as good as platinum etoposide, not better. What about refractory? I think, again, dismal outcomes with various agents that are used, including the irinotecan, docetaxel, gemcitabine, etc., etc. So clearly, when we talk about small cell lung cancer, and particularly in India, it's a systemic disease, majority of patients presenting with advanced stages. And for most of us, a platinum etoposide is the standard first-line option. I feel most of us would be starting carboplatin etoposide rather than cisplatin etoposide. And a very small number of patients in India would actually receive a platinum irinotecan in the first-line setting. Outcomes or results in India, I think fairly dismal. While we look at the analysis from the Western countries, 5-year outcomes are to the tune of 10-11%. Unfortunately, the Indian scenario, the 5-year survival rate are less than 5%, and there are hardly any patients who survive, go on to live for 5 years. As I said earlier, while chemo works well in terms of responses and majority of patients would have a response to first-line therapy, the median PFS is dismal. And if you look at data from single centers, probably as high as 6 months, but I think in my own personal experience, probably as low as 4-5 months. Median OS is also 10 months are standard. Counseling of our patients is that the median survival is about 10 to 12 months for most patients who present with this disease, and hardly any of these will go on to live for 5 years. So the major challenge clearly has been how to improve outcomes. Now, immunotherapy has led to some improvement in outcomes in non-small cell lung cancer, and clearly there was a lot of interest in exploring immunotherapy in this setting as well. We've had various drugs which have been evaluated. We've had the evaluation with atezolizumab in the IMPAR-133 that I'm going to talk about. Other monotherapies like pembrolizumab have been evaluated, some PFS advantage, no OS advantage. And there's also been an interest around nivolumab, ipilimumab, again, failing to show a significant advantage. There's a lot of sense in combining immunotherapy with chemotherapy. We know that the combination will work well. We know that chemotherapy will lead to release of cancer antigens, lead to higher presentation of the cancer antigens, lead to priming and activation, which would actually make the tumor more immunogenic and therefore will actually enhance the benefit of immunotherapy. And so there's a lot of sense in combining the two, but we've been waiting for more data to show that the combination actually works in the patient setting. So this was the rationale of IMPAR-133. Looking at the dismal outcomes with the previously existing regimens, the idea was to, how to improve outcomes. And the goal was to combine immunotherapy with chemotherapy to try and see if a more favorable environment could be created within the tumor to maximize the potential of the immune system to eliminate the cancer cell. So this was the schema. So patients who were eligible had to be extensive stage small cell lung cancer, had to be chemo naive, ECOG PS01, stratified based on sex, performance status, and presence or absence of brain mets, randomized 1:1 to 4 cycles of carboplatin etoposide with or without atezolizumab at 1200 mg once every 3 weeks. Those patients who had a partial response or at least a stable disease could go on to receive maintenance atezolizumab, while those who were on the chemo alone arm would receive a placebo. And the co-primary endpoints were investigator-assessed PFS and overall survival, whereas the secondary endpoints included overall response rate, duration of response, 6 and 12-month PFS, 12 and 24 months OS, and the TTD in patient-reported lung cancer symptoms. So PCI was permitted at the end of chemotherapy. We know in our usual clinical practice, PCI is often considered, and so this was allowed. Consolidative radiation therapy to the thoracic disease, while has been used in select patients with extensive stage lung cancer, was not allowed. And while it is considered, it was not considered as the standard of care, and therefore was not allowed in this trial. What about the choice of chemo regimen? So while there was initially some criticism as to why carboplatin was used, we know that there are 4 trials which have actually compared carboplatin with along with etoposide versus cis-in-eto, and a large meta-analysis of all these 4 trials went on to reveal that the outcomes in terms of median PFS, median OS, and overall response is actually equivalent or nearly equivalent with carboplatin etoposide versus cisplatin etoposide. And we know that carboplatin has lower renal, neurological, and GI toxicity, while it may have some higher hematological toxicity, and therefore for most of our patients in real-world setting as well, the go-to regimen in extensive stage small cell disease is carboplatin etoposide. So what were the results? So these were the endpoints, as we have earlier discussed, co-primary endpoints, PFS and OS. And so what were the results? So this was the population. The median age in both the arms was about 65 years. Most of the patients, 2/3 were males. most of the patients were either current or former smokers. There was a significant number of Asian patients as well. Most of the patients had ECOG PS of 1. A very small number of patients had brain mets at baseline, about 8% and 9% respectively. I believe majority of patients with brain mets would have worse PS and therefore may not be eligible for the clinical trial. So how did the results pan out? So when you look at overall survival, which remember was the primary endpoint, OS was significantly improved with atezolizumab when added to platinum etoposide based chemotherapy. So median OS was improved from 10.3 months to 12.3 months. This was a 30% reduction in risk of death at milestone of 12 months. While in the chemo alone arm, 38.2% patients were alive. This figure improved to 51.7% for the chemo immuno arm with atezolizumab. And therefore, this is a significant improvement in the overall survival of the atezo chemo arm population of patient. In fact, when you look at the updated OS, so when you look at OS at 18 months, so that's another milestone analysis. The median, about 21% of patients in the chemo alone arm were alive in this trial, whereas when you look at the population of patients who received atezolizumab and chemotherapy, the number was 34%. So the delta was about 13% at 18 months. So 13% higher number of patients alive in the chemo immuno arm, and 3 times as many ongoing responses were seen with the immunotherapy arm compared to the only chemo arm. What about PFS? The investigator assessed PFS was also improved by the addition of atezolizumab to chemotherapy. The hazard ratio was 0.77. And when you look at overall response rates were fairly similar in the 2 arms at about 64% for CR and PR versus 60% for the chemoimmunotherapy arm. So subset analysis, fairly homogeneous results across various subsets. Clearly, what was coming out was that the tumor mutational burden or PD-L1 expression did not, affect the outcomes in any way. I think what's slightly interesting is that the small limited number of brain mets patient, the confidence intervals appear fairly wide. But again, numbers were very small, and therefore, overall, the addition of atezolizumab improved outcomes in most subsets of patients, as seen in this trial. So did the addition actually affect the tolerability of platinum etoposide? Clearly, the data says no. When you look at the treatment-related grade 3-4 adverse events, 67% versus 63% in the atezo versus chemo alone arm. Majority of patients were able to complete all planned chemotherapy. When you look at the number of patients having serious adverse events, so slightly higher at 39% in the atezo chemo arm versus 35%, but not a major difference. And again, adverse events leading to withdrawal, about 11% in the atezo chemo arm versus 2.6% in the chemo alone arm. So this study could be summarized that the addition of atezolizumab actually clinically and meaningfully in patients with extensive small cell lung cancer. In fact, this is one of the first studies in more than 20 years which has led to an improvement. There's also a median improvement in median PFS. Hazard ratios sitting fairly impressively at 0.7 for OS and 0.77 PFS. And in fact, at 12-month OS, there was a delta of 13.5% with more than 13.5% or greater improvement in outcomes with atezo chemo versus chemo alone. So not surprisingly, most international guidelines acknowledge the improvement in outcomes, and both NCCN and the European Medicines Agency actually now recommends the combination of atezolizumab with carboplatin etoposide for treatment of first-line patient with extensive stage small cell lung cancer. And these are the general treatment guidelines. So I'll quickly summarize and say that IMPAR 133 is the first positive trial of an immunotherapy drug when added to chemotherapy combination for first-line extensive stage small cell lung cancer. The combination of atezo, carbo, eto is a major advance. And in fact, in 20 years, we have not had any meaningful improvement until we had this study. Based on the results, it is now recommended by NCCN, ESMO, and other key treatment guidelines for patient treatment in the first-line setting. The study demonstrated superior survival benefit with the addition of atezolizumab, with a median OS of 12.3 months for chemoimmuno versus 10.3 months for the chemotherapy alone arm. And 52% patients were alive at 1 year in the chemoimmuno arm versus only 38% for the chemo alone arm. And in fact, now we have other studies which are looking at all-comer population, regardless of biomarker status, to see whether we can shed more light to the data. Thank you very much for your patient hearing. And with that, I hand back the stage to the organizers. Thank you once again.
Thank you, Dr. Devdutt. And with this, we come to the end of the day 1 of the series of lectures on the various aspects of management of non-small cell lung cancer to small cell lung cancer, starting from neoadjuvant to adjuvant settings, and then going to metastatic settings, and also covering a wide array of all different types of cancers, starting from ALK, EGFR positive cancers to PD-L1 expressing, and then Dr. Jyoti was also mentioning that even in non-PD-L1 expressing tumors, how immunotherapy is becoming so important. And at the end of the talks, we had a fascinating talk by Dr. Devrat, where he elaborated how the landscape of small cell cancer has evolved. So I would like to thank all of you for joining us today on day one, and the sponsors for today, AstraZeneca, Pfizer, Roche, and Spring Hope, and my organization Max Healthcare for putting up this show. And we are being watched across various platforms live with more than 150 delegates joining us from various platforms. And also, I invite you to day 2 tomorrow, because we have an international speaker from London, and we're going to be having a huge, I would say, kind of academic feast on day 2. So do join us tomorrow. And with this, I'd also like to thank, in the end, but not the least, the Horizon Conference Private Limited for always having such a wonderful show, and the tech team and all the organization being seamless. With this, good night to all of you. Aru and your team.
Good night, sir. Thank you so much for joining. Thank you, everyone. And we'll meet tomorrow at the same time. Till then, we say bye. Good night.
Bye. Good night.